the goal of the talk is to go through its clinical manifestations, the diagnosis of myelopathy, its grading, the underlying pathophysiology is important to understand as we understand its natural history, and obviously in consideration of treatment options, the radiographic and imaging workup considerations, as well as then the treatment, including non-operative and operative management with the recent techniques that we now use. So just as an underlying start, myelopathy should not be confused with myelomalacia, which is a radiographic finding. Myelopathy is a clinical manifestation, which is really characterized by the chronic compression in ischemic nature of the spinal cord. And this usually happens with patients over 55 years old. So the clinical manifestations is something you will evaluate the patient for, whereas the radiographic findings you may see is myelomalacia, but we'll go through that is not necessarily always the case. It really is a conglomeration of three things that come together, which can present in a very confusing way when you're evaluating these patients. The patient can have these three subset of problems of radiculopathy, an axial skeletal pain, even an appendicular extremity pain that's peripheral, and or be myelopathic at the same time. So the clinical presentation really is underlined by these three things in a truly myelopathic patient alone. Gait instability, the use of walker, cane, or assistive device. And this may be in a patient who also has osteoarthritis of the knee and believes that the balance are giving ways because of that. However, it actually may be more central. Diminished proprioception and balance difficulties. Using handrails and having frequent falls would be the biggest red flag. Fine motor skill and coordination can be diminished in patients. Often the questions that will lead to eliciting that decline is whether the patient can perform activities of daily living like buttoning a shirt, turning a doorknob, typing on a keyboard. Grip strength can be decreased, so patients should be asked whether they can open jars. What's important to note is while the patient may have these subjective findings and tell you they have decrease in weakness or coordination, grip strength, the main takeaway in a clinical evaluation should be whether they can have a steady Romberg test when their eyes are closed, palms are facing up. And the key thing here is that their feet should be together when they're performing this test to see if their gait and balance is stable. Because as they're standing there for 30 seconds, their feet, if they're not together, they can compensate and maintain their balance, giving you a false sense of their balance. The other thing that you'll see is pronation of their hand when their palms are up over the course of that 30 seconds. You can have intrinsic wasting and ulnar release, which is the inability for those intrinsics on the ulnar side to remain extended when asking them to remain with their fingers completely extended. In terms of coordination, the one other thing that should be commonly tested is grip and release, opening their hand and closing their hands. This should be performed in a normal patient 20 times in 10 seconds. So looking at moving on to the radiographic findings that are evaluated in this degenerative pathology in the spine, there can be several different hallmark features that cause the progression of the spinal cord stenosis. And some of these we'll talk about maybe overlapped with congenital stenosis in a patient at the cervical spine level. But the degenerative changes that will progress are posteriorly the facet hypertrophy, and which is underlying instability. There is then degenerative spondylolisthesis and subluxation. Anteriorly, the disc herniation and bulging, as well as posterior osteophytes off the body, can cause significant stenosis in a chronic nature. Ligamentum flavum, as well as an ossified posterior longitudinal ligament, OPLL, which we'll talk about in surgical considerations, is important to recognize also. And in the imaging, it may be difficult to assess with radiographs, certainly also as well as MRI. So a CT scan in those patients is to be considered. So the pathophysiology in this degenerative condition really is structural and functional abnormalities in the spinal cord. And it's caused by both static factors. So these can be congenital spinal canal stenosis, cervical spondylitis, as well as the dynamic factor, which is the repetitive spinal cord damage caused by the instability that's formed. So both of these things together cause microvascular disruption, and that leads to the cord ischemia, as well as then the mechanical stretch and compromise of the blood-brain barrier has been thought to lead to edema in the cord. And as a result, you have recruitment of the inflammatory cell neuroinflammation cascade, and the end of the line would be chronic inflammatory changes and potentially accelerated cellular apoptosis and gliosis. Going through that pathophysiology, if there's a disruption and a lesion in the lateral corticospinal tracts, and the anterior horn cells are then affected at the biochemical level, the glutamate at the neuroreceptor level in the anterior horn is going to be affected by having postsynaptic upregulation, and there's decreased presynaptic glutamine release. And so then the lower motor neuron becomes hyperexcitable, leading to a hyperreflexive pathway through that inner neuron pathway. And eventually, like we talked about, the end of the line would be the anterior horn atrophy. So going back to the three components that may overlap in terms of radiculopathy, myelopathy, and axial pain, the patient can come in hyperreflexive, myelopathic sense and have upper motor neuron signs such as Hoffman, hyperreflexic upper and lower reflexes, and an inverted brachioradialis reflex, or may have a mixed signal if there's a combination of radiculopathy at the same time. In terms of how we grade the degree of cervical myelopathy, there's really two main grading scales. One is the modified Japanese Orthopaedic Association scale, and this takes into account the motor and sensory as well as sphincter dysfunction of the patient, and is graded with each upper, lower sensory and sphincter function or dysfunction. 18 should be normal, and if a patient is below 18, then they have some degree of cervical myelopathy, with less than a score of 8 being in the most severe category. The other classification that's used is the Neuro classification for myelopathy, and this goes to rate the patient based on whether they have radicular involvement, cord involvement, functionally if they have a gait imbalance, and if they have employment. And I think it's more of a functional classification, however, probably lesser used, especially when it comes to research. Most of the studies will use the modified Japanese Orthopaedic Association scale. In terms of its epidemiology, cervical myelopathy is non-traumatic and related to degeneration in the vast majority of patients that we see. However, you can have acute injury in these patients that causes a significant central cord syndrome in a myelopathic patient, leading to exceptional weakness after the injury. The true incidence is probably unknown, but studies have said up to 20 to 60% of patients will have some degree of cervical myelopathy in the general population, wide range. The genetic predispositions that can cause a patient to have a increased predisposition, most commonly in the cervical spine, Klippel-Feil Down syndrome, Ehlers-Danlos, can all lead to congenital stenosis or subluxations, causing instability and increase in hypertrophy of those joints that we discussed to cause significant stenosis. As we talked about the natural history of that degenerative pathway, most patients will decline in a stepwise fashion, and this was really kind of a seminal paper in the 50s that was performed following patients with these myelopathic symptoms for approximately greater than 10 years, and they found that only 5% had a very rapid decline in function, and 20% have a slow decline, whereas 75% will plateau and have a stepwise decline, plateau, and then have a stepwise decline. So the same studies have shown 20 to 60% overall in a systematic review have mild symptoms, which will continue to show this type of stepwise decline. And really, in terms of its impact, this natural history study showed that most patients with mild myelopathy can be safely observed and have clinical follow-up 3 to 6 months per year, every 3 to 6 months for progression of symptoms and weakness. So non-operative treatment is an option for patients with mild or even moderate myelopathy that is stable. Systematic review of 5 major studies showed that there's no difference between operative and non-operative with a modified Japanese orthopedic score of more than 12. Again, below 8 would be severe, so this is moderate to mild patients that were treated in operative versus non-operative management. The same study, though, tended towards rigorous non-operative treatment, was potentially skewed towards improvement. However, this study should be considered for its selection bias because the most severe patients would obviously be indicated and have surgical management to prevent progression of the cervical myelopathy. So if there is trauma in these patients, that's the biggest thing to underlie and know that asymptomatic stenosis, 7% of those patients with non-OPLL had new deficit, whereas if you had a diagnosis of pre-existing myelopathy without OPLL, 24% of those patients had new deficit in the setting of a minor trauma. However, if it's in the setting of a combined OPLL and minor trauma, these patients that have a pre-existing diagnosis of myelopathy have 87% of a new deficit. So this is something to also counsel patients on in non-operative management, is their increased risk for a potential of a significant neurologic injury with a low energy mechanism of trauma. It's a reasonable option to consider non-operative management with mild symptoms. However, because of the increased in their risk of neurologic decline in a patient with moderate and severe, it's not a reasonable option to continue to manage these unless there are surgical contraindications for the patient. So one of the other studies that looked at whether stenosis is correlated with symptomatology in these patients is patients who had imaging-based stenosis and what their evolution to cervical myelopathy was. They had calculated risk factors. We'll go through these, and they had about 44 months of average follow-up in these patients. Sorry, this came out quite blurry. I hope you can see, but the risk factors they looked at were demographic age above 50, and the relative risk factor was about 1. Males have a little bit more of a predisposition, but clinically they found that presence of a symptomatic radiculopathy were very significant with a risk factor of 3.0, as well as electrophysiological diagnosis with SEPs and MEPs both having approximately a factor of 3 increased risk, as well as if EMG picked up anterior horn lesions. So in patients with OPLL, the severity of the spinal stenosis, if it was more than 60% of stenosis, 100% of those patients had developed myelopathy, and the way they label it is that 100% did not develop myelopathy in the course of that follow-up, meaning that the overlying of OPLL and cervical stenosis, more than 60%, would deem the patient to progress clinically to having myelopathic symptoms. So in a patient with radicular symptoms, you should be more cognizant and aware that the patient has a risk factor to present with myelopathic symptoms at some point. An estimated risk is 5% per year for 20% at 4 years, obviously, in the setting of these symptoms. I'm sorry, radiographic findings. In a retrospective review of 148 patients undergoing surgery for cervical myelopathy, this study from 2014 looked at not only the modified JOA scores, but also the radiographic appearance of signal attenuation in the MRI findings of T1 and T2 to see if there's any correlation in their prognostic outcomes in these patients. And they actually found that T2 signal had no predictive value in the improvement of the modified Japanese Orthopaedic Association score postoperatively. However, they did find that if there was a dark signal on T1, that was a poorer prognostic indicator, which really goes to affirm our treatment goals in these patients undergoing surgical management is not necessarily that we are looking for improvement. There is evidence to show some patients may find improvement. The overall arching goal should be to prevent the progression of the cervical myelopathy in these patients undergoing cervical surgery.
Hey, so can I stop you for 2 seconds?
Yep.
Because this whole T1, T2 signal change has been a big topic, and people talk about a lot. And I think this is a great study. But one of the things I've never been able to find, and I wonder if you came across in your reading, is what's the risk of? I mean, we see a lot of people with increased signal on T2, and it's more difficult to pick up dark signal on T1 sometimes. But what's the risk of someone with, and you certainly, so you want to, this seems to indicate that you want to you want to intervene before T1 signal dark occurs. But do we have any sense of what the time course, that time, like if you see a high T2 signal, is that going to be predictive of a T1 signal change within a year, 2 years, 3 years? Never. Has anyone ever looked at the kind of the time course to signal change in terms of which develops first? First you get T1, T2 signal, then you get T1 signal, or they happen simultaneously? Like, does anybody know what how to predict when the T1 signal will turn dark?
That's exactly what I was looking for, Dr. Gelb, in reviewing this talk, but there hasn't been any studies that I'm aware of that showed what the progression timeline would be from having a T2 signal change, which would be more acute and hyper-intense edema that shows up, versus the chronic T1 changes that you can see that show the later end of inflammation and granulation, basically.
Or if T2 signal change is even predictive of the development of T1 signal change. I mean, maybe you can have T2 signal change and it doesn't even mean you're ever going to get T1 signal change. I don't know. I'm asking, does anybody know of any natural history MRI follow-up studies that look into how signal change develops over time?
I'm not aware of any timing of the natural history of, patients that have been followed with clinical or subclinical myelopathy that have signal changes and, what occurs and what's the clinical correlate. I'm unaware of that. However, I am aware of studies that do post-mortem evaluations of patients that have had T2 and T1 dark signals, and the only thing that I've read is that a T1 darker signal is correlative with somebody that has gliosis, right? That it's a sign that the neurons are dead and there's just scar tissue inside the spinal cord. So that's probably why a darker T1, has a poorer prognosis with regards to recovery or maintenance of their neurologic status.
Right. I guess it should be interesting to get a sense of whether T2 signal is an indication for surgery because it is predictably followed by T1 signal change, or it's something we can just ignore and base our decisions on clinical exam factors in terms of, because here it seems that T2 signal is not going to tell you about improvement. So if you have someone with mild myelopathy, but a high signal in their T2 in their cord, should you push that person more strongly towards surgery? Or should we treat them like other mild myelopathies and say, well, we can observe this because it's only mild?
That's a really good question. Also, it'd be so hard to, I imagine, get a study going where you follow these patients, especially now, with significant myelopathy that we're continuing to manage non-operatively. I can't imagine that cohort is very large, especially from what we see. Potentially patients that are continuing to have non-operative treatment by other providers or have sought surgical evaluation but declined. I imagine it'd be hard to follow forward.
Sorry, Sohaib, to interrupt. That's a very fascinating area, and I've been kind of looking on the periphery on people that are trying to track traumatic brain injury with a blood test. So could that be applicable to look at neuro damage in patients with progressive cervical myelopathy? Very interesting to see what comes out of the TBI and blood tracking. Can we apply that and adapt it to progressive cervical myelopathy? And those are collaborators at University of Maryland that are kind of working with that kind of concept with TBI.
Yeah, so far I think clinical and the imaging-based modalities are really the only way to continue to follow patients' progression. That would be definitely additive. Moving on to our surgical outcomes, I think there's been a very large study that should be mentioned in the talk of surgical management, which would be the AO Spine North America trial multi-center prospective that included 278 patients with 12-month follow-up. Diagnosis would be myelopathy to be included with MRI evidence. The outcomes they looked at was the Neck Disability Index and JOA classification, neuric, and functional scores with SF-36. The procedures they included were decompression both anteriorly, posteriorly, or combined in these patients. And they found that in nearly all areas, patients did demonstrate improvement. Those with actually severe myelopathy and score of MJOA less than 10 had the most amount of improvement. The mean improvement in the MJOA was 2.88 without any significant functional decline postoperatively found in these patients. So this is that chart looking at their overall improvement in the score. However, if they parse it down, the next table that they showed was mild, moderate, and severe, in which patients showed the most amount of improvement at 12 months. You can see on the top right, 4.91 was this average of the severe category improvement, as well as improvements in both the SF-36 and less disability on the NDI.
Just remember, there's a significant ceiling effect to that analysis, because if you have mild myelopathy, you don't have that much that you can improve.
Right.
The score tops out at 18. And if you have severe myelopathy, you have more room to improve. So, to say that the most severe people got the best improvement doesn't mean they ended up with the best function, because they may have started so low that even with a significant improvement, they didn't get to where the mild people were.
Preoperatively correct.
Yeah, that's an important point to understand, but I think the other take-home message, from this paper, and everybody should really get into the granularity of this paper. It's a very strong paper. Is that sooner is better than later for myelopathy. So for those patients that even have mild myelopathy that have a subjective acknowledgement of a decline in their level of function, I think those patients should be offered surgery, because overall they're functionally better.
Getting into whether anterior or posterior surgery is more beneficial, efficacious in these patients. There are a few systematic reviews looking at studies. One of these more recent systematic reviews looked at 8 studies that showed no difference in the JOA scores and compared the canal diameter change improved with posterior approaches overall. The pseudoarthrosis rates were lower in a posterior-based surgery. They found no difference in C5 palsy rate, which was around 8 to 10%. Infection was also lower in the anterior surgery cohort, and pain was lower in the anterior surgery cohort. So although a lot of these factors are known risks and benefits to both anterior and posteriorly based cervical surgery, really at the end of the review, they found individualized approach is the most important when you're choosing which surgical management you should provide to the patient. Another thing to keep in mind is patients with tandem stenosis, both cervical and lumbar. There was a study out of Japan that looked at the natural history of the asymptomatic lumbar canal stenosis in patients undergoing cervical myelopathy. They had a diagnosis of lumbar canal stenosis on imaging, and most patients this lumbar stenosis do not require a decompression later, meaning there's no role for prophylactic decompression. And further, the priority has been shown to be given to the cervical stenosis in patients where a lumbar stenosis is symptomatic as well.
Hey, Sohaib, I think you got muted.
Sorry about that. Further, this study looked at patients that had tandem stenosis, which was symptomatic, treated with the cervical decompression and lumbar at the same time versus a staged procedure. And they found that although they had improvement in both, there was no real difference in their outcome scores in these patients. So simultaneous decompressions may be an option for these patients that are truly symptomatic at both levels. In terms of surgical considerations in evaluating patients for anterior, posterior, or combined approaches and technical considerations in fusion or non-fusion procedures, this is an excellent overview of the patient characteristics. The level of the cord compression should be evaluated both from MRI as well as X-rays, upright X-rays, and the alignment is important to understand in patients that are undergoing this as well at the level and above and below of that cervical stenosis. With a neutral or lordotic alignment, normal lordotic alignment of the cervical spine, it is anterior, posterior, or combined approaches depending on patient host factors that may play a part. However, when the kyphotic deformity in the cervical spine from the bottom of C2 to C7 becomes more than 13 degrees, really we should be worried about the potential for a drift back phenomenon with a posterior-based approach, because even though a laminectomy posteriorly may be decompressive, the cord may not be able to float back over that kyphotic deformity, which would be unaddressed. There's a modified K-line that came out of a Korean spine group, which looks at the level of kyphosis, whether it's positive or negative. Positive meaning that the compression is dorsal to that K-line, whereas negative meaning the compression is all ventral to the K-line, which is drawn on a T2 sagittal image from C2 midpoint of the spinal canal to C7 midpoint. And then additionally, radiographic findings, the biggest and most concerning for potential treatment implications would be the presence of an OPLL, which poses a very real risk to dural injury with that adherent lesion. And this is something that should be considered for a posterior-based surgery to avoid those types of complications. Instability should be looked at on plain X-rays as well as FlexX views, which may not be addressed if fusion preserving or non-fusion procedures are given for the patient. Congenital stenosis, usually it's multi-level and may not be decompressed anteriorly if the patient has congenital stenosis, as well as patients with mixed myeloradiculopathy and foraminal stenosis should be considered whether a foraminotomy or ACDF is also considered at that level for the patients that are symptomatic. Neck pain has been implicated in whether motion preserving surgery like a laminoplasty is even reasonable in those patients. Previous radiation in terms of wound complications should be considered. A history of dysphagia should be considered with a workup with the ENT colleagues, as well as any history of dysphonia or vocal cord priority for patients that are singers or talk show hosts. And then smokers obviously have a limited capacity to heal bony fusions, which has been borne out. So looking at fusion versus non-fusion procedures in posterior cervical spine, there's been multiple studies to look at laminoplasty versus posterior cervical laminectomy and fusion. the systematic review from the Spine Journal and looking at the MJOA, axial neck pain, the VAS change, reoperation, infection, and palsy, found that overall they have similar outcomes. However, there was a trend towards an increase in axial neck pain with laminoplasty compared to fusion postoperatively, and there was a higher trend towards infection rate in the fusion cohort. Alternative options, non-fusion procedures that can be looked into are oblique corpectomies anteriorly, which go from the symptomatic side. It's not theoretically a destabilizing procedure, and also skip laminectomies posteriorly can provide significant decompression. However, the patient that has multi-level stenosis, skip laminectomies may be hard to adequately decompress that spine. So although there's been limited studies, these options do show equivalence when the patients are mild or moderate in terms of their cervical myelopathy. However, certainly these are not the mainstays of treatment in most patients. And just to wrap up, I think it's very important to understand myelopathy is a clinical diagnosis. Myomalacia is a radiographic finding which may be present depending on how much MRI change and for how long in the setting of subacute or chronic changes the patient has. The clinical presentation can be varied with root changes, radicular picture, as well as axial and appendicular compression peripherally. 20 to 60% of the patients with mild myelopathic symptoms will have a decline in their natural history and progression, and it's important to follow these patients clinically with physical examination. And then once the functional decline does occur, usually that's in the stepwise fashion with a plateau stage in between each stepwise decline. The patients with mild myelopathy and contraindications to surgery, it's reasonable to consider these patients for continued non-operative management, knowing that there is a likely stepwise decline. But surgical decompression is effective, and it does halt the progression as well as have some improvement in the patient's myelopathy as well, depending on when the patient has an intervention. Surgical approach really should be tailored to the patient's radiographic parameters, clinical symptomatology, and underlying disease. However, non-fusion procedures may be an option for these patients, knowing that there may be alignment changes in non-fusion procedures afterwards. So that's a brief overview. Any questions that we can address or discussion points?
Yeah, so that was it was a great talk. I mean, you were really were able to sort of deconstruct the literature and bring it together in a very, very coherent fashion. The interesting thing I think about myelopathy, and maybe Gelb and Eugene can attest to this, when I did my fellowship, the teaching was that when we operated on myelopathy, it was really to halt progression, right? And we really did not discuss that the patients would actually improve, right? But now it's so interesting to see all the new evidence that's emerged that we can actually counsel our patients that the expectations are, yes, we are going to be able to halt progression. Yes, we should be able to improve a lot of the symptoms that you're describing, right? So I think that's a really important point. You guys are in the era of training where we're discussing these things with our patients, but that's sort of been a more recent evolution, over the past even 4 to 5 years, I would suggest, when some of the newer data points have come about. I think the only other interesting thing that you touched on, and I'm really glad you did this, is I think we see a lot more tandem stenosis, issues, and it is not uncommon for people to present, with severe degenerative lumbar stenosis, radiculopathy, neurogenic claudication, and then you get into the details of what they're describing. But more importantly, you examine those patients because you really need to rule out an underlying, occult myelopathy that's commingling or coexisting with their stenosis, and it's a challenging conversation to have. Somebody with back and leg pain, and they've been worked up and they've been treated for months, years, etc. And just for them to understand that, hey, they do have that problem, but they also have a problem in their neck that needs to be addressed first. I think some of those papers that you brought up, the two, there was one Korean study and then there was one by Pat Connolly I'm familiar with, where they did them and they said that one of the options is to do it simultaneously. Our experience, and one of our fellows, Amit Bandugia, looked at that. In our numbers, about 26% of people that had their neck done. I don't know if Dan or Eugene remembers these numbers, but I believe that about 26% of patients that had their necks done did not have to have their lumbar spine addressed. Did you come across any data points that were suggestive that if you addressed their neck first, that it obviated the need to go?
Yeah, there are smaller studies that were published, small series, small numbers, that did say tandem stenosis, mainly dealing, although with patients that were asymptomatic in their lumbar spine, meaning that they didn't have.
No, I'm saying the opposite. I'm saying patients that present with lumbar spine problems, we figure out that they're myelopathic, but it takes care of their lumbar spine issues.
Oh, I see. That I did not find.
I think, and I've certainly seen that occur. We've had people that has occurred. More importantly, from Amit's paper, was that of the people who had tandem stenosis that was unrecognized, and we did a lumbar procedure first, or we recognized it and still said, oh, the lumbar is much more severe, they're more symptomatic, we're going to do the lumbar spine first. About 50% of those people ended up with new neurologic problems related to their cervical spine. So by not addressing the cervical spine first, we had a 50% rate of neurologic deterioration. None of it wasn't severe. Nobody ended up quadriplegic necessarily. But I think that it points out that you really want to, if you can identify that there's a tandem problem, in order to avoid that deterioration, because 50% is pretty high, you probably ought to address the cervical first, or at least concurrently, simultaneously, because I thought that was probably the most important finding in our paper, was that when we didn't do the cervical spine first, there was a fairly high rate of deterioration in those patients.
Any other questions, concerns?
I wonder whether, we see lots of people who we diagnose with myelopathy, and the MRI is not always terribly impressive. Sometimes the compression, you see lots of people with worse compression who are really not symptomatic, and you wonder why some people's cords are so sensitive or whatever is going on. And I wonder if we ought to be sending people for preoperative electrophysiological, not just EMG nerve conduction studies, but preoperative SCP. We showed that the electrophysiological stuff is highly predictive of progression of myelopathy, except other than clinical radiculopathy, right? The SCPs were the highest predictive value factors for progression of myelopathy. So I wonder if we ought to be utilizing electrophysiology more in our mild myelopathy patients who we're considering whether or not to observe or operate. And I don't know whether we even have the facility, and with the electric guys here, if they're still around, do we have that capability of doing outpatient EP monitoring to answer some of those questions?
Yeah, I think that is probably going to be a challenge. Number one, I don't know. A lot of them are on the conference. It would be nice to hear if anybody's thoughts on their end. I wouldn't even know how to operationalize that, with regards to making somebody comfortable sticking leads in their head and getting their SSE. I don't I think that would be a challenge in and of itself. EMGs are also predictive. I remember in that, I believe, so you could probably validate this. I think EMG studies also were helpful.
Yeah, EMGs were definitely, if you see fibs and sharp waves, if you see signs of denervation in the from anterior horn cells,
right,
that's clearly predictive. But also EP, and I don't know. I know when I was with Bridwell, occasionally we would send people for preoperative electrophysiology, but I don't know that we ever did it very commonly, and I don't know if these guys have any experience with doing outpatient awake EP monitoring.
I mean, I guess the question is whether or not, if you have a patient that was symptomatic, had some objective neurologic findings, but had mild to moderate canal stenosis, and you're unclear whether or not, but you're not impressed with it, and they acknowledge a decline in the liver function, the SSEPs and the EMGs really should not drive your decision making. You're probably going to operate on them, or you're going to tell them to get another opinion, or.
Yeah, I understand. I mean, I think we have lots of people who have lots of subjective complaints, and not a whole lot of clinical findings.
Right.
And then and the MRI is kind of middle of the road, and you say, well, they say their hands aren't working well, but right. They don't have but they don't really have atrophy, and they don't have a Hoffman sign, and they're and they don't have lower extremity hyperreflexia because they have tandem stenosis or diabetes, and you're kind of, is this really myelopathy? Is this diabetic polyneuropathy? What to do with those folks, and I'm just looking for any other things I can hang my hat on before I make treatment recommendations. And it just occurred to me that maybe I haven't, like I said, I just thrown it out there.
Well, I think the important thing to understand is that remember, there's mild myelopathy, moderate, and severe, right? And you're just dealing with the mild form, right? And I think it's important also to understand that, if you wait long enough for somebody to struggle getting into the office because they can't ambulate, to have intrinsic atrophy in their hands, right? And to have all the objective findings on their physical examination, that's severe myelopathy. You probably waited too long. Unless you're dealing with somebody with an acute massive disc herniation, right, that shows up to the ER, right, that less than 5%, or a traumatic injury, obviously, that's caused a traumatic spinal cord injury, right, that type of quote-unquote myelopathy. But if you waited for all those things to occur, then you probably waited too long, and you've probably done a disservice. If you are following somebody for that, right? Alternatively, if the patient ignores it, they don't understand, their primary care doctor misses it. That's sort of my experience with these things for patients with end-stage myelopathy that show up to our office, are that either the diagnosis was missed, or patients sort of just try to persevere on and just get through life. And then there's some proverbial straw that breaks the camel's back, and then they just can't walk anymore, and they show up in a wheelchair. So I think it's important to understand that there is an element, there is a diagnosis of mild myelopathy, and we may want to be more aggressive in those patients because we know they do better.
This is Kavanaugh. Can you guys hear me?
Yep.
Yes.
So to Dan's point, I got burned pretty early in my career operating on a patient or two who presented with cord compression, and I was like, oh, they're myelopathic. But they had some fasciculations and things like that, and they ended up having like neurodegenerative conditions like Lou Gehrig's. And I talked with a neurologist, and oftentimes that denervation pattern in the anterior horn could be seen in some of those neurodegenerative stuff. So it's difficult to tease out after my discussion with some of the neurologists. So I'm not sure that is 100% the answer either.
Right. Well, I mean, that's the point. We don't want to be operating on people who don't have the disease, and although you can say that people do well, and they do, there's no question. You only have to have one or two people who have complications in the operating room, a bad C5 palsy that never fully resolves. That you're not necessarily making everybody better.
Yeah, I agree.
Complications occur, and you got to deal with those as well. And to your point about neurodegenerative diseases, if you're not doing a full cranial nerve exam, if you're not looking for tongue fasciculations in every single person who you're making the diagnosis of myelopathy on, if you're not checking that they don't have normal pressure hydrocephalus, there is a differential diagnosis to be considered, and you can't just say, oh, they've got a disc bulge and some mild cord compression on, and they're having a little trouble with their hand function. I'm not asking to wait for people who are in wheelchairs, but I'm also saying that there's a differential, and you don't want to be operating on people who don't need surgery.
Yeah, I very vividly remember a patient that came into my office one time who had dense hemiparesis of her right arm and right leg, and had horrible cord compression, but the exam never really correlated, right? It was too focal on one side. So I sent her for a brain MRI. She actually had like a massive brain tumor, so obviously there's, you have to think higher up the chain, to your point. And then secondly, I don't know if anyone's ever looked at like a logistical regression analysis, of the patient comorbidities, right? Like the degree of their diabetes or coronary artery disease, or, those medical things that can affect, the blood supply, like microvascular blood supply, and looked at the degree, correlated that with how squished the cord was. Because I see a lot of younger patients that are relatively healthy that have high degree of stenosis, terrible cord compression, but they get by, right? Because their blood supplies may be better, they compensate better or whatever. But it'd be interesting to do logistical regression analysis, and looking at age and the degree of cord compression, or medical comorbidities and the degree of cord compression. I don't know if that's out there.
I know out there is looking at prognostic factors with how well patients do after surgery. So that patient population you described, the degree, the duration of their myelopathic symptoms, their ambulatory ability, and medical comorbidities, diabetes, coronary artery disease, obesity, and T2 weighted signals are all correlated with, poor neurologic outcomes after their surgery, right? But I'm not quite sure they answer the question that you just, picked up on.
Yeah, I just always am thinking, like, I see patients that have very minimal cord compression, but they're pretty myelopathic, and then I see patients that have terrible cord compression, they're like, get by okay, and it's always like, what factors, am I missing?
Dan, there was a whole slew of, new MRI techniques about 4 or 5 years ago. Alpesh Patel looked at this at CSRS, looking at blood flow to the spinal cord. I don't know anything that came to fruition with that, Steve. Do you know? anything that happened with the new MRI sequences to look at the blood flow to the cord?
Yeah,
Yeah.
the diffusion tensor imaging.
Yeah.
Yes.
Yeah.
Yeah. I think that has been published. The problem with those technologies, and that was when Alpesh was in Utah. The problem with those technologies is that they're just not available to everybody, right? I mean, these were radiographic research techniques that they used, and I'm unaware of those technologies being generalized, anywhere else other than in Utah, maybe at other larger, facilities like a Mayo or something like that, Cleveland Clinic, but I'm not aware of its being, generally accepted at this point. Well, any other comments? Great talk, so spectacular job as always.
Appreciate that. Great talk at the end.
Any other comments? Dan, Eugene, Cavanaugh? Gelb? I think the only thing that I want to leave on a note, because Gelb and Cavanaugh brought this up. I remember when I was in Pennsylvania, I saw this cardiologist, and I don't know if Dan Gelb remembers this, in the office, and he had a painless foot drop, and he couldn't walk, and I evaluated his lumbar spine, and because I said, oh, maybe he has a disc herniation, but he didn't have any pain, and he had nothing. It was totally clean. And I said, I'm not quite sure what was going on. And I said, maybe we should get a neurologist to see him. And he was so concerned. Instead of going to the neurologist, he went to see another spine surgeon in the community. And that spine surgeon said, oh, you're walking funny. And that was because he had a foot drop, right? And he's like, oh, but you're walking funny. And I think you have spastic paraparesis. He was probably about 45, 50 years old at the time. And he ordered an MRI scan of his cervical spine. And of course, he had cervical stenosis. And that surgeon did a cervical laminectomy on him without a fusion. And I think Gelb brought this up. Postoperatively, he developed somewhat of a spinal, sort of a multi-root nerve root palsy. It wasn't just a C5 palsy, but he had like a 5, 6, 7, I remember, palsy. And he came back to see me in the office, and because he's like, I don't know what's going on. And, the other surgeon was scratching his head. And I said, you need to go in to see a neurologist. And he went in to see, Dan, do you remember Zach Simmons? I don't know if Gelb is on the call. Zach Simmons, who is who's the preeminent neurologist for ALS, and the guy ended up having ALS, and he died in 6 months. Died in like 6 to 9 months, but he had progression of his myelopathy. I think the point is that you really need to make sure you correlate somebody's history, their physical examination findings, to their advanced imaging studies before you jump on anybody. So I'll just leave you with that anecdote.
All right, thank you, everyone. Have a great day.